Thank you, BD, for giving this opportunity to me. So my job is very simple, is to let you have fast dinner. Uh, I am going to convince you on something which is quite obvious. Yes, we have to go for venous access, a better venous access in all cancer patients. Yes, both port and PIC are the standard of care now. And yes, we have to look at all individual patients while choosing. But how do we look at it is that we have to understand the global guidelines, we have to see the Indian practices, the viability, the feasibility of the lines and the port. We all know and been practicing for 17 years now. Since I started, taking a cannula is the most difficult part, both for the patient and for the nurses. And we've always wondered, why can't a cannula be punctured in a vein again, especially in chemotherapy patients? Now we know the answer. Chemotherapy burns the vein, and we have to find better solutions. Do we need to use an algorithm for PICC line in cancer patients in India? Yes. Indian cancer patients end up taking a lot of pricks in their arms, and you can recognize most of the cancer patients by tattooing of the veins when you see them. And I think the time has come that we all stand up and create an awareness that this is not the way to go. When we look at the global guidelines, the incidence of extravasation is high across the globe, up to 22%. 70% of the patients will develop phlebitis, and I'm telling you, even blood transfusion leads to phlebitis in cancer patients. The veins are very fragile, and they keep complaining of pain. I get to see in most of my clinic, if there was an ice which was available from a marketing company, I think that marketing company will be rich, because a lot of my patients are on ice therapy post phlebitis. We have to avoid this. Options, critically ill patients, we all see them with a cannula, with a line in their neck. But for cancer patients, I think port, tunnel catheters, or PICC line is the answer. We have to say no to peripheral lines, because the outcomes in cancer is improving, and these patients end up receiving close to 15, 20 cycles of chemotherapy. And we have to just say no from first cycle. I mean, I feel there is no point in trying 1 or 2 cycles, even with the peripheral line. When we look at the global guidelines, this is Michigan guidelines. Even patients who undergo frequent phlebotomy, they recommend usage of PICC lines. And across any duration which is above 5 days, they recommend PICC lines. And I was debating this with my colleagues in the hospital, with the emergency department, is that any patient, we do cater to a lot of patients with diabetic foot, and they end up being in the hospital for a month. And I was telling them that any patient who is expected to stay for more than 5 days, please put a PICC line, because in future it becomes very difficult to treat them for anything if you don't put a PICC line. There are various aspects, of course, what type of chemotherapy we are using, what is the duration of indwelling catheter, the vascular integrity for individual patient, what is the intensity, frequency of the dose, and patient appropriateness. For all chemotherapy agents, vesicants, irritants, they do cause some sort of phlebitis. Especially for vesicants, we have to use a central line. Irritants also, 5-FU is terrible. I mean, you get these snakes over the arms, and I wonder sometimes, these patients will be, religiously picked up for no reason. So consider CVAD for all patients. This is my message, especially for patients who require repeated transfusions. All the guidelines recommend that patients who have to use a line for more than 7 days do consider PICC line, and the PICC line can stay for many years. My patient, the maximum that I've used, one single PICC line, is up to 1.5 years. So it's a relatively safe procedure. This was a study which was, from the other center, which said that they looked at 269 PICC lines, and the median duration of catheter was up to 184 days, just 6 months. And I think the reason for removal of the catheter was the end of the use. But the highest was 1384 days, and that is about 3.8 years. And I'm sure it must be a bad PICC line. I get to use that in my practice, and it does really well. We overestimate systemic therapies. A lot of patients have to undergo pricks again and again, and the common problem that patients tell me is, sir, meri body mein blood khatam ho gaya, because they cannot take the blood out of my vein. So what I I want to imply them that the veins have been punctured by people like us. The blood is still there. And if you were to get a blood withdrawal from PICC line, it's a good option. For a lung cancer who are not on immunotherapy, up to 74 pricks in an year, it's unacceptable today, and it will be acceptable tomorrow. For ovarian cancer, you can see these patients are undergoing multiple lines of therapy, and it's unacceptable to keep pricking these two arms every time, especially in women where the veins are not so good. So the barriers, cost is the barrier. But if you would see the total cost of central venous catheter or a PICC line, it's much lesser than the chemoport. Central lines are not, PICC lines are not associated with hemothorax. I've had one patient who had undergone a port insertion and developed a hemothorax immediately after that, and the surgeon had a terrible time. And I had a terrible time. I had to delay the chemotherapy by a month, and I go back and I regret that I should have put a PICC line to that patient. None of my PICC line patients have developed any issues. The other advantage of doing a PICC line is that if the patient is in a peripheral setting, you can always ask a GP or a nurse to remove the PICC line if they develop fever. With the port, if you have a pneumonia or a port infection and the line stays in the system, then it can be life-threatening. I've lost one patient who was on biological therapy, but there was a lung infection and they could not remove the port overnight, and I think it is unacceptable. Most of the centers, including mine, we are doing nurse-led PICC lines. So nurses are doing, we are training them. The cost is reduced. USG guided, now we are putting PICC lines in more and more first line. So we are not requiring USG guided, but USG guided PICC lines removes all complications. BARD also runs a stronger program with Center of Excellence across the country. And our nurses go get trained at Tata, and they are supported by BARD. So we have trained 4 nurses so far, and they are very particular in putting PICC lines. And I must say that they put it better than me. These are the PICC line centers which BARD supports the nursing training, and they do get a certificate of excellence for putting a PICC line afterwards. And I think this is amazing. Again, this is about the program. So they have done a lot of workshops across the time period. Of course, during the COVID time, the number of workshops had gone down, but I think we are picking up, and as 22 is coming, we have increased the amount of workshops. Now also one more limitation has been solved. We have sutureless stat locks, and these can be replaced by any nurse. So I encourage all my colleagues here, pulmonology colleagues or other colleagues, that these are very, very safe, and especially for people requiring long antibiotics for 15, 20 days. These are very safe. Patient can go home with these locks. Also, we have pre-filled flushes now, and that's what the nurses are using at both the centers that I practice. It reduces the chances of PICC line damage because these are all 10 ml syringes. It stabilizes the pressure, and it's very easy to use. So, and there is no confusion in the nurses that they have to use a HEP lock because these are all pre-filled with saline. So in summary, for any chemotherapeutic agents, in fact, for all of them, either there will be a pH issue or there will be a osmolality issue. Please use central lines. TPN patients, these patients do require TPN, and they do bless you once you have done a PICC line up front, and eventually they would need. Getting a blood sample is easy. I do all my AMLs in the induction with the PICC line. And the advantage is once you've done with the induction, you just remove the PICC line and you observe the patient for neutropenia. And there is no catheter, nothing inside. So patient is very happy. We need to make habit of checking the venous status. And most of the hospitals have now venipuncture teams. And I think it's time that at a massive level that we go and promote the usage of chemoport and PICC line. And we must give this option to every patient. I think this is more imperative. We are still having extravasations. Many oncologists are having cases under them. Unfortunately, I am also one of them. So, but this has to become a habit. With this, I would like to end my talk, and I would like to encourage you for the mistakes that we've done in our practice. Please go ahead and use a central line and do not give chemotherapy from a peripheral line. Thank you.